problems that you see in the cornea, and they're not, believe me, that so rare. Problems of neovascularization in children, problems of scarring in children, which may need to be treated, or at least may need to be prevented before coming there. So let's start with opacities. These kind of opacities, these are photographs from children that come from our pediatric clinic downstairs that we have with Nick Kojais, and they come up, and we have to do something about these children. If these kind of scars are superficial, yes, we have a very good chance of improve visualization, improve the vision just by doing simple PTK laser and maybe extinguish the haze, this little haze, or improve the transparency, and that may improve the visual potential of our little children. But why this happens? Why do we have new vessel formation or scarring in our little ones? These are these three major causes, which I believe if we start addressing them the right way, we may prevent this end result of scarring and neovascularization. So don't forget, first of all, as we say in the morning, herpes simplex can happen in children. We have many children that improve by getting Valtrex or anything else similar to Valtrex, even in a very, very young age. Don't forget some of the slides that I will show you, because are very important for you. Don't miss any of these three situations in children, and don't forget to treat them vigorously, because otherwise you will have scars, you have neovascularization, and that is a problem. So forget about causes and causes. I want to point out that when it's superficial, it's panos, it's easy to do something about, but when the vessels are deep, then it's more difficult to treat them, and we are running out of real options. And vessels need to find space to enter into the stroma. They cannot invade just a stroma which has nothing as a problem. So treat the problem so that they won't find space to enter. Once they enter, they will have lipid, they will have deposits of other deposits like calcium, they will have also scarring. Let's go first to the herpes simplex keratitis. And if you don't remember anything of what I will say in the next 7 minutes, just remember that it's very common, that it can happen in both eyes in children, and that it doesn't start with the dendritic ulcer. It doesn't have to be a dendrite to be herpes simplex virus. It can start with stromal. So if you see something unusual starting in a child in the corneal stroma, at least try to start treating it with local steroids and oral antiviral. You may do something very early and good. So be careful that it can be bilateral, especially with children with atopy and asthma, so we have the two things coming together. The recurrence is very high, so you need to treat these children systemically for the follow-up, prophylactically. And the late diagnosis is the #1 problem that we have in these kids. So if it's keratitis, it's simple. We know what to do. We just put everything topically and treat it. And also don't forget to treat sometimes in skin lesions that do happen, even in simple virus, in children. This is a case of a 10-year-old child that started bilaterally, as you can see, and was much better in the initial diagnosis, and then with steroids and long-term, or let's say with almost a year of valcyclovir, now things are improving or at least stabilize. And the parents were really very anxious because they were looking of scars developing in the eye, and they couldn't do much about this. Also another bilateral case of a child, you can see left eye and right eye. First manifestation, it is like that, and it's herpes simplex. You can see now more, and here also you can see deep vascularization. So acyclovir dosing, I think the best way is to discuss with a pediatrician of how to start the dose of acyclovir in these children, but I strongly recommend valcyclovir as your first choice, even in children. Recurrences, the best way to get away from recurrences is to use the prophylaxis on this. Blepharitis. It is not so uncommon to have blepharitis in children. What is uncommon what is actually common is that we don't treat blepharitis in children, and then they develop different kind of problems. So don't forget, go back, remember how blepharitis is in adults. Usually anterior is in children. Don't forget that Demodex is not so common. And don't forget that blepharitis, the mainstay of blepharitis, is a chronic inflammation, which again will start and give you this vicious circle of again and again. If you don't stop the circle, the problem will go on and on and on. And we start from this, which is an easy situation to deal. You start with chalasia, and you end up having neovascularization of the stroma, and then things are going to be more difficult to treat. One thing not to forget, we cannot give doxycycline, but we can use topically azithromycin, and also we can use azithromycin orally as well in children in a long-term dose. So don't give doxycycline. This is the only thing that you have to consider in children, but you can use all the other standards as well as steroids for the treatment of anterior or posterior blepharitis. Parasitic, very rare in children, I wouldn't even bother to talk about. The third problem, vernal keratoconjunctivitis. We have discussed so much about atopy in this day in our Congress. Please, just in every child, see if there is atopy. If there is atopy, treat it vigorously. Treat it with steroids, treat it with cyclosporin. You can even treat it without FDA approval with other agents that are in use, and we cannot actually say what agents are, but I can tell you about in our party later on. But when you see these things are also with these plaques, this kind of problem in the cornea, that you know, the shield ulcer. And why is the basis of this shield ulcer? Because vernal keratoconjunctivitis has a strong relation with cytotoxicity, with interleukin and with TNF factor. So all these things are fibroblast stimulations, which do what? Stimulates scarring. So at the end, they start with just an atopic disease, which will end up with neovascularization and scarring and long-term astigmatism and bad visual acuity, and maybe a problem in a later as they grow. And the way the new vessels come is simple. We know that as they come for every other case, even in the posterior segment of the eye. This is how we can stop that. We can use VEGF, anti-VEGF, of course. And we can try to stop the creation of space, which usually happens with metalloproteinase and interleukins. So two ways. One, to stop the inflammatory reaction, which will create the space and the vessels will grow in. And two, once the vessels are already there, try to do injections or drops of anti-VEGF that we know we can use in adults. Now we can use it even in children. To stop angiogenesis, you can see here the result just of steroids into angiogenesis. And here, this is an adult, of course, but the same can happen in children. I just sedate them for a while and do an injection when I have neovascularization in children to stop neovascularization. This is just with one injection of Avastin, and you can see the result. So please, please, please think about these cancers and give our children a chance to have a clear cornea. Thank you very much.